Okay. So again, welcome to the webinar. Happy Home Care and Hospice Month to all attendees from our parent company Procura, from Igea Home Health Software, and Diverse Medical Group. And welcome to the Billing and ICD-10 implementation. What we'll do first is provide a brief introduction of Procura and ourselves as moderator and presenter. Secondly, our presenter, Leysi Casanova, will discuss our main topic. We'll provide comments on how tech is relevant, and we'll finalize with answers to attendee questions. Now, we've had the pleasure of meeting some of our attendees in the past, okay? But I'd like to introduce Leysi Casanova, an entrepreneur and president of Diverse Medical Group. She brings over 12 years of experience in home health billing and over 14 years in the home health industry. My name is Brian Nieves, and I'm one of the regional sales managers for the Igea Home Health Software brand. My tenure at Igea Software is approaching its 7th year, and I've worked for home health agencies and hospice providers, so I've had a little bit over a decade of experience interacting with healthcare providers. Now, a little bit about our company, our parent company, that is Procura. It was established back in 1989, so over 26 years of experience in the tech industry. Procura runs operations in the US, Canada, and Australia. We've implemented software in over 2,300 locations, and our services reach over 1.7 million patients daily. So what I'll do now is hand it over to Leysi, which will present on our main topic, billing and ICD-10 implementation. Enjoy.
Hello, everyone. Thank you for attending today. I'm excited to share this webinar with you, for I feel you'll get a lot of important information, not only on the topic, but also some updates and upcoming changes. Let's get into our webinar agenda. Today, we will actually be going over some home healthcare billing basics, the billing process, some ICD-10 basics, a little bit about ICD-10, the coding process, updates, and the final rule, which gets implemented on January 1st, 2016, some expected issues, and understanding what has changed. And last but not least, I will leave you with some resource links to where you can get some additional information in regards to the topics we'll be talking about. Now, for home healthcare billing basics. As a lot of us may know, HHPPS stands for Home Health Prospective Payment System. Medicare pays home health agencies a predetermined base payment for each 60-day episode of care provided to a Medicare beneficiary. These payment rates may vary and/or be adjusted due to numerous contributing factors, some of these being beneficiary's health condition, care needs of a beneficiary, adjustments for geographic differences in wages, outlier payments, and case mix groups assigned to an episode, also referred to as HHRG, or how I like to call it a HERG, which is determined by the data completed in the OASIS. Now, a HERG reflects on a home health claim as a HIPS code. Home health payments are made in 2 installments. First, we start off with our RAP, also known as our initial payment or our type of bill 322. A RAP stands for Request for Anticipated Payment. RAPs have the same from and through dates and are generally, for CMS purposes, not considered a claim. However, our RAP on an initial episode would pay out 60%, and on recertification episodes or following episodes, 50%. Then our final claim, also known as the end of episode bill or type of bill 329, a final claim has different from and through dates, being that we're closing out our episode, or we've finished treatment, or we finished with that 60-day episode that belongs to us and recertifying to continue for another certification period. On an initial episode, our final claim would pay the remaining 40%, and on recertification episodes, the remaining 50%. Now, a quick overview of our billing process. We would get our OASIS data completed, over to completing our plan of care and sending it to the referring provider. We would also get our face-to-face certification out, export our OASIS data, submit our RAP, continue obviously with our case, get our POC, all of our plan of care, all of our orders, our face-to-face certification signed and received, as well as all our notes. Once we have everything in that we need, we submit our final claim. Now, let's go a little over the ICD-10 basics. What is ICD-10? ICD-10 now contains up to 7 characters. Character 1 always being an alphabet. All letters are used except for the U. Character 2 always is a numeric character, and characters 3 to 7 may vary between alpha and numeric. Now, in ICD-10, we also have new, the placeholder X. Considerable differences between the ICD-10 code set in comparison to the previous ICD-9 are that it's considered to be much more specific, has laterality, which is used and has been added to relevant codes, contains more combination codes, now codes fractures, which in the ICD-9 we did not. We actually referred to these as our V codes. The alpha characters are not case sensitive in the ICD-10. This is great because this eliminates our risk of claim rejections due to this that we would see in the ICD-9. And finally, the ICD-10 codes are solely used on the OASIS 1. Now, a quick overview of our coding process is we would complete our OASIS C1 data, get it over to our quality assurance for review, we code our case, generate our plan of care, and hand it off to billing. Now, I want to give you a quick overview of the updates and final rules effective January 1st of 2016, which I'm going to speak about. This does impact and will impact financial reimbursements. So we will be talking about Medicare open enrollment, the CMS Final Rule 1625, which includes home health prospective payment rate updates, the ICD-10 coding guidelines in regards to initial encounters, and the VBP model that will be implemented as of January 1st. And last, we will also be talking about the change request 9369. Okay, so CMS Medicare open enrollment for coverage year of 2016 began on October 15 of 2015 and ends now on December 7th, 2015. Please note and advise beneficiaries that if the December 7th deadline is missed, they will not be able to make any changes to their enrollment until October of 2016. For more information in regards to the open enrollment, you may visit Medicare.gov or call 1-800-MEDICARE. Now, why do I give this reminder in regards to the Medicare open enrollment? Being that we're actually on the Medicare open enrollment right now, I advise everyone to run routine eligibility checks. Why is this? As a lot of us may have experienced in the past or know, being that we are on open enrollment, a lot of the time during this time frame, a lot of our beneficiaries and our patients either enroll in another program or another Medicare provider that maybe we do not accept or do not provide services to. Or in some cases we have seen they get enrolled and aren't even aware. Sometimes the Medicare will ask them if they want to change, and if they don't, they'll sometimes get changed for some reason. This is important that we run routine checks so that we are aware if this has happened and we can catch it in a timely manner so that we don't lose time and money. Now, Final Rule 1625, effective January 1st of 2016, updates the home health prospective payment system rates. I'm not going to get too into detail about this, but I do want to give you some of the key important information so that you can have it. I'm pretty sure a lot of people have wondered what kind of monetary impact this will have, and I hope to clear that up for you now. Now, the CMS is implementing the third year of the fourth year phase-in of the rebasing adjustments to the national standardized 60-day episode payment amount, the national per visit rates, and the non-routine supply conversion factor. The rebasing adjustment for calendar year 2016 will reduce the national standardized 60-day episode payment amount by $80.95. However, it will increase the national per visit payment amount by 3.5%. And this 3.5% is of the national per visit payment based on the calendar year 2010, with the increase ranging from $1.79 for home health aid services to $6.34 for medical social worker services, and reduce the non-routine supply conversion factor by 2.82%. In the calendar year of 2015, Final Rule 66072, CMS finalized the proposal to recalibrate the case mix weights every year with more current data. Okay, in Section 3B1 of this rule, they are recalibrating the home health prospective payment system case mix weights using the most current cost and utilization data available. In addition, in Section 3B2 of that rule, they are finalizing reductions to the national standardized 60-day episode payment rate for calendar year 2016, 2017, and 2018 of 0.97% in each year to account for estimated case mix growth unrelated to the increases in patient acuity, also known as the nominal case mix growth, between calendar year 2012 and calendar year 2014. Now, this is important for me to touch base with you guys. The ICD-10 initial encounters, this has been a conflicting factor in the past and was actually discussed in the final rule. The ICD-10 initial encounter coding guidance regarding the 7th character assignment for diagnosis codes under Chapter 19, which are injury, poisoning, and certain other consequences of external causes, which we would see in the ICD-10 as codes S00 through T88, were revised in the draft 2015 ICD-10. The completed official draft code said, and this was based upon the 2015 revised coding guidance, certain initial encounters are considered to be appropriate when the patient is receiving active treatment during the home health care episode. The decision to eliminate the 7th character initial encounter for the S and T ICD-10 code set from the home health prospective payment system ICD-10 translation list was based upon not only the most current coding conventions and guidelines that were available at the time, but also in collaboration with the cooperating parties of the ICD-10 Coding Committee, which include the American Health Information Management Association, the American Hospital Association, the Centers for Disease Control and Prevention National Center for Healthcare Statistics, and CMS, who confirmed that the initial encounter extensions were not appropriate for care in the home health setting. Code extensions D as in David, E as in Edward, F as in Frank, G as in Go, H as in Harry, J as in Jake, K as in Kilo, M as in Mary, N as in Nancy, P as in Paul, Q as in Quarter, and R as in Robert indicate that the patient is being treated for a subsequent encounter, which is, in this case, care for the initial during the healing or recovery phase, and were included in the translation list in place of the initial encounter extension. CMS provided the draft translation list to the public on the CMS website. Now, let's discuss a commenter's comment on this, because you might be asking yourself, well, Leysi, what do you mean by this, and what do we consider an initial encounter? I'm going to quote a comment from one of the commenters, and this comment is actually noted on the final rule, which in the resources I've given you a link to. The final rule, as you know, is almost 100 pages long, so I'm really going over the top of this for you. The commenter requested clarification on the use of the 7th character for initial encounters in the home health setting. The commenter agrees that it seems reasonable that traumatic injuries codes with the initial encounter extension may not be appropriate. However, the commenter also contends that certain initial encounters extensions may be appropriate if the patient is still receiving active treatment. The commenter provided an example of an active treatment whereby the patient is receiving an active treatment with continuation of antibiotics for treatment of a postoperative infection. Based upon this example of active treatment, the commenter recommended that CMS revise the home healthcare grouper to allow the reporting of the initial encounter 7th character for the ICD-10 codes for those conditions that could reasonably continue to receive active treatment in the home health setting. A couple of other commenters noted similar concerns regarding this initial encounter. However, the response was, while this comment was outside the scope of the actual rule, they recognized that the calendar year 2014 final rule 72271, they discussed the decision to eliminate codes with the initial encounter extension listed in the GEMS translation for ICD-10 codes that begin with S&T as that are used for reporting traumatic injuries. An example of this would be fractures and burns as part of the ICD-10 grouper conversion effort. Codes beginning with S&T have a 7th character that indicates whether the treatment is an initial encounter, a subsequent encounter, which is a residual effect of a condition produced after the acute phase of an illness or an injury has terminated. Now, like I said, in regards to this topic, the rule goes a bit further. I've provided here on the slide, as you can see, a link to get more information of that, and I'd be happy to give any further information in the future. Now, let's move forward to our home health, our HHVBP model, actually. Beginning January 1st, 2016, CMS will be implementing the HHVBP model, which stands for Home Health Value-Based Purchasing. For all home health care certified agencies providing care to Medicare beneficiaries throughout 9 selected states. These 9 selected states are Massachusetts, Maryland, North Carolina, Florida, Washington, Arizona, Iowa, Nebraska, and Tennessee. This was authorized by Section 1115A of Section of the Social Security Act. This task is to identify whether payment incentives can significantly change providers' behavior to ways that shift home health agencies to value-based purchasing and improve quality of care. Now, it is my opinion that this merits a lot of attention, especially for those of you located in any of these 9 states that were selected for this model. Medicare certified agencies selected for the inclusion of the HHVBP model will be required to compete for a payment adjustment to their current PPS reimbursement based on quality and performance. A competing home health agency is defined as an agency that has a current Medicare certification and that is being paid by CMS for home health care services delivered within any of the states selected in accordance with the HHVBP model selection methodology. Now, let's keep in mind that this model is believed to promote and help identify value-based purchasing versus volume-based purchasing. This, in my opinion, merits the attention, like I said, because when it comes to our OASIS data, this is where they're getting this information from. They're getting it from our OASIS data, quality assurance programs, performance improvement plans, and all of these things impact that data. For now, our reimbursement may be affected in either both a positive way or negative. However, for those of you in these states, I urge you look further into this and get as much education as possible. Change request 9369 was released by CMS on Friday, October 16, 2015, providing additional G-codes that will differentiate registered nurses and licensed practical nurses or licensed vocational nurses in the home health care and hospice claims. Change request 9369 establishes new G-codes for different levels of nursing services provided during a hospice stay, and home health episodes of care. These two G codes and the retirement of G0154 will be effective on institutional claims and types of bill, as you see on the slide, for hospice dates of service on and after January 1st, 2016, and for home health episodes of care ending on or after January 1st, 2016. The new codes are G0299 for RNs, registered nurses, and G0300, which will be used for LPNs, LVNs, which is licensed practical nurses or licensed vocational nurses. The two codes, G0299 and G0300, has been implemented to allow the Medicare Max to appropriately pay hospices for RN visits during the last 7 days of life in the routine home care setting, where those visits are eligible for the service intensity add-on. You may get further information about this if you see the MLN Matters number MM9369. Now, I want to put emphasis on this. Let's talk about continue to talk about the change request. Here are 3 topics that I wanted to bring up. Some software systems may not currently be prepared to handle this change, especially with home health, while other systems are easily adaptable due to having effective dates for the codes, and the system administrator will just need to add and change the new codes with the appropriate effective dates and give a termination or expiration date to the G0154. Those of you that have Igea don't really have to worry about this because they've got it down pat. The most important thing to have in mind with this is education to staff responsible for selecting the appropriate codes and scheduling, ensuring that they are ready for this change and are aware of how to correctly schedule and select these codes once the change takes effect. Keeping in mind, of course, that incorrect code selection or scheduling when automatically pooled on a claim submitted electronically may cause the claim to either not go through to Medicare and or get rejected or RTP'd, returned to provider. Therefore, it is my advice to ensure your billing staff be made aware of this change, of course, so these errors may be prevented head on. This is, of course, recommended to agencies that may also key in their claims manually, for this needs to be changed that way as well. Now, finally, a lot of you may be wondering and waiting for me to mention G-code G0164, which is teaching and training, which is also used for both RNs and LPNs, LVNs. This code, according to the rule, will remain as G0164. So when it is to be used for a home health patient, there will be no differentiation between the RN and the LPN or the LVN. I just wanted to make sure that I mentioned that. Let's go over some expected issues. Obviously, improper coding, and this can vary for many reasons. One, coders' understanding of the new code set. I like to say we don't really have what we can call ICD-10 experts. Why? Because this is new. So we're all really learning it, and it's more of the understanding of the code set than anything. Using manifestation codes as a primary, forgetting to use the X indicator, and or adding the 7th digit as needed or when required can also impact improper coding. Again, I mentioned software readiness. As some, if not all of you, may have already experienced, any new changes, softwares are expected to encounter issues and require workaround solutions temporarily, of course. This includes the Medicare Common Working File. I don't know if many of you might have encountered this because I don't know how many of you here are actually billing staff, but just a good reminder, in mid-October, home health care claims with episodes that span October 1st, 2015 were being incorrectly rejected and returned to providers with reason code 31276. The system fix for this issue was implemented on October 23rd, and this was on the Medicare Common Working File. However, RTP claims or return to provider claims received after the system fix was implemented were returned to the provider for correction, What does this mean? This required billing staff to refresh the claim via the DDE, not recommended to resubmit a new claim. Next, billing staff readiness to identify rejections and denials are some other expected issues that we were expected to come across. Increased denials, rejections, and return to provider claims. Increased coding turnaround time. What does this mean? Since we are dealing with a new code set, it is expected that our coders will now take a little bit more time to actually get these cases coded, and this is totally normal and expected. Delayed claims processing, and improper G-code use or scheduling. Now, please keep in mind, both ICD codes are expected to be used up to 12 months after the ICD-10 implementation. And Medicare expects up to 10% increase in claims issues including but not limited to denials and rejections 3 to 6 months after the implementation. So we are still well within that window. Understanding what has changed. Some of the things that we've reviewed here. Code sets used on the OASIS C1 and claims may differ. Addition of the 7th character, when a 7th character applies and is missing the codes, will be invalid, causing the claim to have issues. Placeholder X is now used in certain codes. When applicable, must be used in order for the code to be valid. MO90 or MO090 determines which code set is used on the OASIS. However, as of 10.1.15, episode dates determines which code set is used on the wrap and or on the final. Translation of the codes may be needed. Code changes may vary on the final claim in comparison, obviously, to our wrap. OASIS C1 and final claims are compared now to verify HIPS code matches. The Home Health Prospective Payment System updates have been made. ICD-10 initial encounter codes have been updated. And the Home Health Value-Based Purchasing Model implementation effective January 1st, 2016 will be effective for those 9 selected states that I mentioned. Also, services provided by an RN, registered nurse, will be coded as G0299. And services provided by an LPN, LVN, licensed practical nurse or licensed vocational nurse, will be coded as G0300. On all home health claims, effective January 1st, 2016, terminating G code G0154. Now here, please find some links to where you can get more information in regards to these topics that we spoke about. And I will return you with Brian to talk about how tech impacts this.
Thank you for that valuable information, Leysi. Again, if you logged in a little bit late, Leysi is part of Diverse Medical Group. In fact, the president of that company, a company that provides billing services for outsourcing, Medicare, Medicaid, HMOs, billing audits, and also HR management. So I'm going to talk to you a little bit about how tech is relevant to what she just discussed. You're looking right now at a screenshot of Igea's point of care system. When caregivers enter an ICD-9 code, it is easy for them to go ahead and convert the ICD-9 code to ICD-10. It's literally a click away. And so I'm going to go ahead and point at that right now, convert here to ICD-10. Igea's point of care is compatible with any device. And we also offer it in an application which works offline. Okay. Here we see the ICD-10 converted on this following slide that we have here. And you can also see here that we have the Medline Plus integration when a code is entered, which provides teachings on the diagnosis in multiple languages. Okay. The application helps agencies bill and get paid quicker than handling paper-based operations, given that caregivers don't have to physically turn in paperwork. We've designed Igea's point of care with valuable user feedback to provide the easiest yet most complete experience possible. Also, when online, QA is able to see documentation in progress in real time, which is something that's valuable. And Igea point-of-care forms are completely customizable. So providers may have the exact content they need on documentation in Igea point-of-care without incurring hefty customization fees. Finally, there's significant automation when using this product, Igea point-of-care, for home care providers. Once an assessment is approved by the QA, items missing during the intake process are populated automatically. Care plans are created automatically. Visitation frequencies land in the schedule. So all you need to do is tell the system, tell Igea, which caregiver to send, and Igea will automatically plot all the visits. And finally, the system will go ahead and organize all the documentation into the patient's or client's electronic medical record. All of that is happening once the QA approves the documentation, that you see here. What you're looking at now here is the same back office ICD-10 conversion, again from the back office application in Igea. And here we're looking at one of our billing advising tools, which allows you to facilitate the optimization of reimbursements. And that once you run this at the QA level, the system is going to point out all the weaknesses that you have as far as billing goes and explain to you how a different answer may generate a different score. Of course, we recommend that a director of nursing reviews everything to ensure that changes are warranted, but nonetheless, the system is explaining to you how your billing is affected based on the answers that you provided, something that we have integrated, something that allows you to avoid having to export your OASIS out of the software system and then import it into a third-party application, which is how most services for billing advising work today. So with Igea, it's just a click within the QA component and you're all set. Okay. For some payer sources, such as Medicaid, we know that electronic visit verification is important, and Igea offers it via GPS. Here we see an example of the system picking up the patient's location with Google Maps, picking up the caregiver's location, and determining if the device that the caregiver is using once logged in is within 100 feet of the patient's home. In this case, it's within 64 feet of the patient's home. And so this visit will be deemed as verified, and here we see the time at which the visit was verified itself. So this is electronic visit verification via GPS within Igea. And for those providers that have a lot of caregivers that may not have a smartphone, no problem. They can use electronic visit verification via telephony. Okay, so this will allow the caregiver to call in from the patient's home and clock in. So for example, here I have Brian Nieves, the caregiver, which attended Ernest Hemingway. On this particular visit, I notice here that he clocked in at 3:35. As soon as he clocks in into our proprietary telephony system, the icon will change there, as you can see it. Okay, and the system will also have show those that have not been verified by telephony. And this is always in real time. As soon as you click refresh at the QA level, you'll be able to see who has clocked in. The system has also texting power. So if you ever have a caregiver that is a few minutes late, the system will send them a text message saying, hey, Brian, you need to go ahead and clock in. The same if they don't or have not clocked out at the time to clock out, the system will send them both an email or a text message. And you also have additional settings which allow the caregiver and the case manager be aware of repetitive tardiness for clients. So again, if the caregiver does not have a smartphone, we also offer the telephony option. Okay, and then we have just one more slide here for you, again pertaining to the billing discussion that we've had today. New in Igea, and this is the automatic payment posting for non-Medicare. For your Medicare, if you're using Igea, you already know that we've had that now for a good amount of time, but now we also offer it for waivers and commercial insurance. As you can imagine, this will expedite posting the payment, so you don't have to post a payment one at a time. And it, of course, reduces errors of manual posting. Everything is being loaded automatically from the ERN that you receive. And you just go through this wizard process here that you're looking at, and Igea allocates the payments or posts the payments and allocates them to the appropriate invoices so that you can keep track easily of all the payments that are still owed to you. Igea allows you to track payments both at the invoice level and down to the visit level as well. Okay, so it's very specific. Okay, so this will go ahead and conclude the content that we have for you guys today. We appreciate your time. What I'm going to do now is I am going to go ahead and read some questions that we have from the attendees that we have here for Leysi Casanova. Okay, so the first one being, this is coming from Stacy over at Dade Home Health. Okay, and the question is as follows. What should I do if my claim is rejected? Will I know if it was rejected because it is not a valid code or due to any other claim edit? So I'll hand it off now to Leysi to answer that.
Yes. Okay, Stacy, I can answer that for you. Yes, submitters will know that it was rejected because it was not a valid code or versus any other denial due to any other claim edits. However, submitters should follow the existing procedures for correcting and resubmitting these rejected claims and issues related to any denials or RTPs. And you will see the reason for the denial just like we see it now, either by looking up the code on your EOB or just F1ing your claim on the DDE, and you could see it. The same way you see it now is the same way you'll see it then. They will have a reason code for that. Thank you.
Okay, 2 more questions. We have here a question also from Marisol coming, asking from National Home Health. Do all cases billed to Medicare require RAPs as well as a final claim?
Hi, Marisol. RAPs are not required if the claim is to be billed as a LUPA, or if the claim is an adjustment to a previously established Medicare episode and claim. In all other instances, both the RAP and the final are required.
Thank you, Leysi. And our final question here, this is coming from Mary over at Quality Home Health. For claims rejected with the recent code you mentioned, you said that the RTP claims received after the system fix were done and returned to the provider for correction. Can you elaborate on that?
Absolutely. So initially, the claims were being returned to the provider in error, incorrectly, rejected actually, and returned to the providers. Once the system fix was implemented, all of those claims that actually rejected or returned to provider due to this recent code were automatically set back to suspended for this, and then back to processing so that they can continue to process. However, the edits that the claims that came in and RTP to return to provider after the system fix was implemented were returned to provider, which means in our billing is that they were in T status, and our billing staff would then be responsible for refreshing that claim or F9ing that claim to bring it back into the suspense so that it can process. I hope that answered your question.
Thank you very much, Leysi. So this is going to go ahead, we're going to go ahead and wrap this up now. As we mentioned earlier, we are going to be providing everyone with the slides, also a copy of this webinar if you came in a few minutes late. If you have any other questions, we have here our contact information available for you. We welcome you to give us a call. Even after the webinar ends, we welcome you to call in, reach out to us, let us know if you have any questions, how we can help. And well, we thank you very much for your time today. I hope everyone has a good rest of the day. Goodbye.